Hey guys, welcome back to my channel. If you're new here, my name is Dr. Moshmi Das. In my last video, I finished the series on anatomy of nose. Now one more part remains, which is the anatomy of the paranasal sinuses. So I'll be covering that in this video. Let's start our class now. Today's topic is about the anatomy of the paranasal sinuses. Now what are paranasal sinuses? These are basically air containing cavities located in certain bones of the skull. These are 4 on each side. So what are these paranasal sinuses? They include the maxillary sinus, the frontal sinus, the ethmoid sinus and the sphenoid sinus. So now we are going to discuss each of these sinuses in detail, where they drain into, what are the structures coming in relation with them. So the first sinus we will discuss today is the maxillary sinus, which is also known as the antrum of Highmore. So the maxillary sinus is basically the largest of all the 4 sinuses that we have talked about, and it occupies the body of the maxilla bone. It is pyramidal in shape, with its base getting directed towards the lateral wall of the nose. So this is the base of the maxilla, and its apex, which is this part, it gets directed laterally towards the zygomatic process of the maxilla and sometimes into the zygomatic bone itself. This maxillary sinus, which is this whole region over here, this is the maxillary sinus. It has a capacity of 15 milliliter in an adult. It is 33 millimeter high, 35 millimeter deep and 25 millimeter wide. And via its ostium over here, as you can see, it drains into the middle meatus. So this is the maxillary sinus. Now we need to know about the ostia. So the maxillary ostia, the normal ostia of the maxillary sinus, is usually ovoid, meaning oval, and tunnel-like, having 3 dimensions, whereas the accessory ostia which is more easily seen, it is actually circular and has only 2 dimensions. And the relations of the maxillary ostia is that inferiorly is the inferior turbinate, 1 to 2 mm superiorly is the lamina papyracea and the orbit, posteriorly lies the posterior fontanelle, and 0.5 cm anteriorly lies the nasolacrimal duct. So this relation is very important to know in relation to the maxillary ostia. The maxillary ostia, so we have to differentiate between the normal ostia and the accessory ostia. So very important feature which helps us in differentiating is the fact that the maxillary ostia is ovoid and 3-dimensional, and the accessory ostia is circular and 2-dimensional. Next we move on to the relations of the maxillary sinus. As you can see from the picture here, the anterior wall, which is this one, is related to the facial surface of the maxilla and related to all the soft tissues of the cheek. The posterior wall, which is here, the posterior wall is actually related to the infratemporal and the pterygopalatine fossa. The medial wall of the maxillary sinus is related to the middle and the inferior meatus. So you can see this is the medial wall, which is also known as a base, and it is related to the inferior meatus and the middle meatus over here. And at places this wall is actually very thin and it is membranous. Next comes the floor of the maxillary sinus. So this is the floor of the maxillary sinus. It is formed by the alveolar and the palatine processes of the maxilla, and it is situated 1 centimeter below the level of the floor of the nose. Usually it is related to the roots of the second premolar and the first molar teeth, as you can see right over here. So this is forming the floor of the maxillary sinus. And lastly remains the roof of the maxillary sinus, which is formed by the orbital floor, and this roof is actually traversed by the infraorbital nerve and vessels. So these are the different relations of the maxillary sinus. Next we move on to the second one, which is known as the frontal sinus. So each frontal sinus, it lies in between the inner and the outer tables of the frontal bone, above and deep to the superior margin. supraorbital margin. So this is the frontal sinus over here, as you can see. So the two frontal sinuses, they can often be asymmetrical, and there is usually an intervening bony septum in between them. This septum is thin and it can often be obliquely placed, or it even may be deficient. It may be absent on one or both sides, or it may be very large, extending into the orbital plate at the roof of the orbit. The drainage of the frontal sinus is through its ostium into the frontal recess. When I have described in my video on the lateral wall of the nose, I have told you how the frontal sinus via its ostium drains into the frontal recess and goes to the middle meatus, and I have shown you how all these frontal sinus, ostium and the recess, they form an hourglass configuration. Next, coming to the relations of the frontal sinus. The anterior wall of the sinus is related to the skin which lies over the forehead. The inferior wall is related to the orbit. So you can see over here, this here is the orbital roof. So the inferior wall of the frontal sinus is related to the orbit and its contents. And lastly, the posterior wall, this one, as you can see over here, this is the posterior wall. This is related to the meninges and the frontal lobe of the brain. Next, we move on to the third sinus, which is the ethmoidal sinus. Now, there is a lot you need to know about the ethmoidal sinuses. They are actually very thin walled air cavities lying in the lateral masses of the ethmoid bone. It varies in number from 3 to 18, and clinically the ethmoidal cells, they can be divided by the ground lamella or the basal lamella. This is also something I described in detail when I was telling you about the attachment of the middle turbinate. And the middle third portion of the attachment of the middle turbinate, which is lying in the coronal or the frontal plane, is what is known as the basal lamella. This lamella divides the anterior group of ethmoid sinuses from the posterior group. So the anterior group is opening into the middle meatus and the posterior group is opening into the superior meatus. So when you talk about relations of the ethmoidal sinuses, the roof of the ethmoid is formed by medial extension of the orbital plate of the frontal bone, which shows depression on its undersurface called the fovea ethmoidalis, and the lateral wall is formed by a very thin plate of bone called the lamina papyracea. Next is, now we will be talking about the anterior group of ethmoid sinuses. So that anterior, at birth, these ethmoidal sinuses, the anterior group, they are about 5 into 2 into 2 millimeter in size, and ultimately they attain their adult size by the age of 12. So there are a lot of group of sinuses that come under the anterior group. First of them is the Agger Nasi cells. Now the Agger Nasi cell, they are present in the Agger Nasi ridge, which I explained in the in my video of about the lateral nasal wall anatomy. So this Agger Nasi cell, they are the anterior most ethmoidal air cell. This is a very important feature to remember. And its medial border is formed by the uncinate process. And the degree of pneumatization of the Agger Nasi influences the position of the superior uncinate process and thickness of the bony nasofrontal beak. Second is the ethmoidal bulla. We already discussed about the ethmoidal bulla, how it is forming an intricate part of the osteometal complex. Next comes the supraorbital ethmoidal cell. So this picture, in this picture you can see this is the Agger Nasi cell, and this here is the supraorbital ethmoidal cell. The supraorbital ethmoidal cell is basically when an anterior ethmoid air cell, it extends superiorly and laterally over the orbital roof. So you can see over here that this is the orbital roof. When an anterior ethmoidal cell is going to lie laterally and superiorly over it, is known as the supraorbital ethmoidal cell. And these cells are recognized on the imaging, giving the appearance of a septated frontal sinus sometimes on the coronal view, and a cell located posterior and lateral to the frontal sinus on an axial view. The importance of this supraorbital ethmoidal cell is that it lies very close to the frontal recess. Therefore, what it can do is that it can cause an obstruction of the frontal recess. Sometimes it can also be falsely mistaken for the true frontal sinus, leading to incomplete surgical dissection. Also, it has been seen that the supraorbital ethmoidal cells, they have been associated with the low position of the anterior ethmoidal artery within a mesentery because these cells pneumatize downward from the skull base behind the artery. Also, when the supraorbital cell is present, the frontal recess will show two openings. In this case, the medial opening is that of the frontal sinus and the lateral one will be that of the supraorbital cell. Next, we move on to the suprabulla or the frontal bulla cell. These are pneumatized extensions above the ethmoidal bulla, up the skull base and on the posterior table of the frontal sinus. These cells can become quite large and mistaken for either the skull base or posterior table of the frontal sinus. So, failure to recognize these cells on preoperative imaging will result in incomplete surgical dissection of the frontal sinus. Next comes the Frontoethmoidal cell. Now this is also a group of anterior ethmoidal cell which is situated in the area of the frontal recess and can encroach the frontal sinus. The frontal cells, they represent the cells of the first ethmoterminal that pneumatize above the Agger Nasi towards the frontal sinus. And these cells, the frontal cells, can actually be divided on the basis of a classification which is known as Kuhn's classification. So type 1 is when there is a single frontal ethmoidal cell situated above the Agger Nasi and below the frontal sinus floor. You can see in the picture over here, this here is the type 1 frontal cell because it is situated just above the Agger Nasi cell, which is this one, and below the frontal sinus floor. Second is the type 2, which is a tier of cell just above the Agger Nasi. This is type 2. Type 3 will be a single cell pneumatizing into the floor of the frontal sinus. So you can see that this is the floor of the frontal sinus and you can see how the cell is pneumatizing into its floor. And fourthly, the type 4 will be an isolated frontoethmoidal cell within the frontal sinus. Wormald further modified this classification to more accurately describe type 3 cells as frontal ethmoidal cells that fill less than 50% of the frontal sinus and type 4 cell as filling greater than 50% of the frontal sinus. Now, why is this classification important? It's because it is to ensure that the surgeon's view of a very large frontal recess lumen will not be mistaken for the true frontal sinus. So, identification of these frontal cells on imaging is very important to prevent a false assumption of a complete surgery. Next is the Haller cells. Now, Haller cells are the cells which are situated in the floor of the orbit or the roof of the maxillary sinus. As you see in the picture, this is the Haller cell. It is an infraorbital anterior ethmoidal cell. Sometimes it can pneumatize into the maxillary sinus and cause obstruction of the maxillary sinus ostium. And importance of this cell is that enlargement of this will encroach on the ethmoidal infundibulum, therefore leading to obstruction of the drainage of the maxillary sinus. So after we have discussed the anterior group of the ethmoidal sinus cells, now we are going to talk about the posterior cells. This posterior cell, they lie posterior to the basal lamina of the middle concha. They are 1 to 7 in number and they open into the superior meatus. They also attain their adult size by 12th year of age. So first we are going to talk about the Onodi cell. Now what is the Onodi cell? It is the most posterior cell of this group and it extends along the lamina papyracea, lateral or superior to the sphenoid, and it may extend 1.5 cm behind the anterior face of the sphenoid. Thus, the Onodi cell, when present, it insinuates in between the otic nerve and the sphenoid sinus. As you can see, this is the optic nerve here, and this is the sphenoid sinus. So, it is insinuating itself in between these two structures. Thus, the optic nerve therefore will produce a bulge in the Onodi cell instead of in the sphenoid sinus. So, importance of the Onodi cell is that the optic nerve and sometimes the carotid artery are related to it laterally, and therefore these two structures may be in danger during endoscopic surgery. And also, how do you identify an Onodi cell on a CT scan? In the coronal view of the CT scan, you will see it gives the appearance of a horizontal septation within the sphenoid sinus. And sometimes these Onodi cell, they can actually be mistaken for the true sphenoid sinus, leading to incomplete surgery. So therefore, application of the maxillary sinus roof or orbital floor landmark will help us identify the level of the sphenoid ostium and therefore lead to complete dissection of the sphenoid sinus. Lastly, after having talked about the frontal sinus, the maxillary sinus and the ethmoid sinus, we are going to talk about the sphenoid sinus. It occupies the body of the sphenoid. The two right and left sinuses, they are rarely symmetrical and are separated by a thin bony septum, which is often obliquely placed and may even be deficient. So the ostium of the sphenoid sinus, it is located high up in the anterior wall and it opens into the sphenoethmoidal recess, which lies medial to the superior or the supreme turbinate. In adults, it is in endoscopy, it is a slit-like or oval, or it can also be round. And in adults, it is situated about 1.5 centimeter from the upper border of the choana. So this is here in the picture is the opening of the sphenoid sinus. And the average distance from the anterior nasal spine to the ostium of the sphenoid sinus is about 7 centimeter. And this is a very important number to remember while doing the functional endoscopic sinus surgery. Next, coming to the pneumatization patterns of the sphenoidal sinus. There are three different types. The first type is the cellar type, which is seen in about 90% cases. Cellar type basically describes sphenoid pneumatization posterior to the sella turcica. So this here is the cellar type, and you can see how the pneumatization is going posteriorly to the sella turcica. The pre-cellar type, which is seen in 9% cases, it describes a sphenoid pneumatization right up to the anterior sella. So this you can see the pneumatization is limited to this part. And lastly, the third type is the conchal type, which is a very rare type seen in 1% cases. It describes a shallow bowl with very minimal sphenoid pneumatization and trabecular bone in between the sinus and the sella. So also, other than these three pneumatization types, the sphenoid sinus can also pneumatize laterally into the pterygoid root, resulting in the presence of a lateral sphenoid recess. Coming to relation of the sphenoid sinus, and why is it important to know about the sphenoid sinus, is there is a differentiation between the posterior most ethmoid cell and the sphenoid sinus. And how do you differentiate them? The first thing is that sphenoid sinus is globular in shape, whereas the posterior most ethmoidal cell will be pyramidal in shape and it will taper to an apex posteriorly. Secondly, the sphenoid sinus opens inferior to the maxillary ridge, and the posterior ethmoidal cells most often open above the ridge. And the roof of the posterior choana and the posterior end of the septum, it can be used as landmarks to identify the normal sphenoid ostium and then widen it to open the sinus. So, we have discussed now we need to discuss the relations of the sphenoid sinus. So, the lateral wall of the sphenoid sinus, as you can see right over here, this is the lateral wall of the sphenoid sinus. It is related to the optic nerve, the carotid artery, the optic carotid recess, which can be seen in between these two structures. And this optic nerve, as you can see, this is the optic nerve and the internal carotid artery. They can be covered by a thin bone but sometimes this bony covering may be dehiscent. So then in these cases these structures lie very exposed, covered only by mucosa. So we have to be very careful during surgery in these cases. And the maxillary nerve may also be related to the lower lateral wall of the sphenoid sinus. Next, coming to the floor of the sphenoid sinus, it is related to the Vidian nerve, which is right over here. The roof can be divided into two parts. The anterior part of the roof is related to the olfactory tract, the optic chiasma and the frontal lobe, and the posterior part of the roof is related to the pituitary gland, which lies in the sella turcica and lies lateral to the cavernous sinus. And lastly, the posterior wall of the sphenoid, it helps in forming the clivus. So these are all the important relations of the sphenoid sinus that you need to know about. So if we had to summarize the drainage of sinuses, in the middle meatus, the maxillary sinus, frontal sinus and the anterior ethmoidal sinuses drain. The posterior ethmoidal sinus drains into the superior meatus and the sphenoid sinus drains into the sphenoethmoidal recess. And knowing about the mucous membrane of the paranasal sinuses is that they are lined by a mucous membrane which is continuous with that of the nasal cavity through the ostia of the sinuses. But however, it is thinner and less vascular when you compare to the nasal cavity, and histologically it is a ciliated columnar epithelium with goblet cells which secrete the mucus. The cilia are more marked near the ostia of the sinuses and they help in drainage of the mucus into the nasal cavity. So this is all about the anatomy of the paranasal sinuses. Thank you for watching, guys. Please subscribe to my channel and press on the like button, and I'll be seeing you in my next video.